All right, we are moving without delay to our uh, presidential invited lecture. And we're extremely honored to have with us today Dr. Jesse Ehrenfeld. Dr. Ehrenfeld is the president of the American Medical Association. He's also a senior associate dean, tenured professor of anesthesiology, and director of Wisconsin's largest statewide public health philanthropy organization, the Advancing a Healthier Wisconsin Endowment at the Medical College of Wisconsin. Active in organized medicine since medical school, Dr. Ehrenfeld believes in the power of digital health and information technology to improve patients' outcomes and radically transform healthcare for the better. Dr. Ehrenfeld is a board certified in both anesthesiology and clinical informatics and has been an AMA trustee since 2014, having served as board chair in 2019-2020. He is also a fellow of the American Society of Anesthesiologists and the American Medical Informatics Association, dividing his time between clinical practice, teaching, research, and directing a $560 million statewide health philanthropy. Dr. Ehrenfeld is one of the most respected national voices on digital health integration and innovation, serving as a consultant to the World Health Organization's former Digital Health Technology Advisory Group and co-chair of the Association for the Advancement of Medical Instrumentation's Committee on AI. He previously served as co-chair of the Navy Surgeon General's Task Force on Personalized and Digital Medicine and as a special advisor, to the 20th U.S. Surgeon General. His research, which focuses on understanding how information technology can improve surgical safety and patient outcomes, has been funded by the National Institutes of Health, the Department of Defense, the Robert Wood Johnson Foundation, the Anesthesia Patient Safety Foundation, and the Foundation for Anesthesia Education and Research. Dr. Ehrenfeld is also a combat veteran who was deployed to Afghanistan during both Operation Enduring Freedom and Resolute Support Mission. It's our great honor and my personal honor to introduce the AMA president, Dr. Jesse Ehrenfeld.
Well, thank you for that very kind introduction, and thank you all for being here. I don't think I've ever seen this many suits in South Beach, but it is always a pleasure to be at a surgical meeting as an anesthesiologist. I always feel like a fish out of water, but if anybody needs their chair or table adjusted afterwards, let me know and I'll take care of that. I know that all of you here understand the enormous pressure on our shoulders at the moment. And throughout my time leading the AMA as president, I have the humbling opportunity to speak with physicians all across the country, and I travel a lot, as well as trainees. And what I hear is about the extraordinary pressure of what it's like to practice medicine in this environment. That paints a pretty grim picture of where we are and where healthcare is in our nation. And it's pretty easy to identify the root causes of these pressures. We've got an in-person system that often puts dollars ahead of patient needs. Too much time on paperwork, not enough time on patient care, greater consolidation, that tips the scales of power away from patient and physician autonomy to corporate bureaucracy. And then we've got all of the advancements in digital health and AI that are raising a lot of questions and concerns about what do these things mean for the profession and the practice of medicine? How do we maintain the humanity of what we do when we touch a patient's shoulder and comfort them, the human element that has defined the practice of medicine throughout the ages? So I believe in a moment like this, physicians as advocates for the profession and our patients come together. It's the only way that we will be able to tackle successfully these enormous challenges. We are the natural advocates because we understand what's actually happening in our systems, in our clinics, in our hospitals. And the AMA has been deeply engaged on all of these topics, trying to advocate for you as we create that pathway forward. So in the 45 minutes that I've been given, I thought I would try to give a little bit of a broader view of what are the health trends across the nation today that we are all facing. How is the AMA working to support you, physicians, and our patients across the country? Era of deepening political division and rising professional burnouts, and examine a little bit about what the AMA and physician leaders are doing to advance health equity and driving innovation across the healthcare ecosystem. So there was a very lovely introduction. Thank you again. I have an 86-page formal academic CV available for download. Just please, for God's sakes, don't print it. But this is the one-slide version of it. I had the privilege of training in Boston, being in Nashville for a number of years, where I still have an adjunct appointment. And for the last 5 years, I have called Milwaukee home. And I have a couple of surgical colleagues in the audience who can attest that I do still see patients. And I want to also give a particular shout out to my wonderful colleague, Dr. Oguji Madokwe, who not only is a wonderful surgical oncologist, but she's also the deputy director of the Advancing Healthcare Wisconsin Endowment, which is the health philanthropy that we run together. So that is me in a nutshell. And of course, a day a week, roughly, I am seeing this view. Of course, no one of you recognize this view because you're on the other side, but this is what I usually do on Tuesdays. So, you know, there's a lot on physicians' minds, as I said a minute ago, and I think it helps explain, you know, how did we get to a place of such tremendous pressure, burnout, and challenges? What's weighing on physicians today? And it's things like expanding administrative bureaucracy and paperwork, increasing hostility, threats of violence, misinformation, and attacks on the evidence that we try to generate as scientists to take care of patients, continued government interference into patient autonomy and medical decision-making, a rising surge of chronic disease in Wisconsin, where I call home. We had a strategy session yesterday for our philanthropy. You know, a third of adults have hypertension, only half are controlled. And we know that that is leading to thousands of preventable strokes, heart attacks, and deaths every year because we continue to have those demographic changes. Of course, we live in a time of tremendous geopolitical instability, economic pressure and uncertainty, and rapid inflation. We have now, unfortunately, erosion of trust in medical institutions. The good news is patients still trust their doctor, just not as much as they used to. And the best data on this is the Gallup survey tracking data. They still trust physicians, they still trust nurses, they do not trust the CDC, they do not trust the FDA, and that is a fundamental foundational problem as we are trying to execute our collective health mission. Of course, we continue to battle the rise in professional burnout, which peaked during COVID. Roughly 2/3 of physicians exhibiting clinical symptoms and signs of burnout, workforce shortages, and all of these questions about digital health, AI, and what's ahead. So I don't have time to get into all of these issues today, but I want to touch on a couple of really important ones. When we talk about emerging healthcare technology, the future of medicine and innovation, you've got to consider the health needs of America over the next decade and how many of the current technology trends will close these health gaps. But we know we have an aging population. By 2050, a fifth of the US will be over 65. This rapid rise of chronic disease burden, widening income inequalities that is creating all sorts of access challenges, health inequities, rising costs of delivering healthcare, surgical services, of course, a shrinking proportionate medical workforce, and unclear what the next pandemic might be. But there's a lot in the news today about bird flu, which is obviously concerning. Now, conversations about physician shortages, they kind of tend to focus on these long-term projections. AAMC data suggests that there'll be a national somewhere between 37,000 on the low end, 100,000 on the high end. It's a big range. Doesn't matter which end of it you're on, it's a big number. And if that happens, it will have a devastating impact on our healthcare system. But that statistic belies the fact that for many, the shortage is here. There are 83 million Americans who do not have access to primary care physicians. In large parts of Idaho, Mississippi, pregnant women can't find OBGYNs to care for them during pregnancy. 90% of counties in the US are without a pediatric ophthalmologist. 80% of US counties have no infectious disease specialist. More than 1/3 of Black Americans live in a cardiology desert. My parents lived just up the street, a couple hours in Jacksonville. They lost their own primary care doctor because the Medicare payment rate continues to plummet and the practice just couldn't take Medicare patients anymore. Obviously, a challenge for many seniors. So when you think about all of that, and then you look at the rise in burnout that continues to plague so many of us, the fact that nearly half of US physicians today are over 55, and medical school applications are up, new schools are coming online, we have expanded the workforce a little bit, but we just do not have the people we need if we continue to deliver care in the same way. So this is a lot for anyone, organized medicine, the AMA, professional societies to fix. We can't do it alone. We can't do it in isolation. We have to partner with one another to address these issues head on. Now, there are a lot of factors that are accelerating those concerning trends, but I want to highlight just one other because it relates to a lot of ongoing work that I'm involved in at the helm of the AMA, which is medical misinformation. Some of it politically driven, some of it from our licensed physician colleagues. For any number of reasons, this spiked during COVID and continues to create confusion and distrust amongst our patients. I still remember the very first time I walked into the pre-op holding area to get informed consent for anesthesia for a patient having a cardiac case. And the patient told me, yes, but I don't want blood, even if my life depends on it, because I haven't been vaccinated for COVID and I don't want a transfusion that's going to give me the vaccine. Bad decision, terrible decision, right? Potentially putting her life on the line. And those challenges continue to perpetuate across so many aspects of care delivery. So there's a lot that we have on our shoulders, a lot of challenges ahead, a lot of drivers of physician dissatisfaction and burnout, creating a new urgency for all of our work at the AMA, but also for everyone else through professional societies to use our influence and our power to be the allies that our patients and our colleagues so desperately need. So when you look at all of the AMA's work, and we're known for a lot of things, it really falls into three core buckets. Getting rid of the junk that gets in the way of taking care of patients, prior authorization, administrative obstacles, the nonsense. Trying to lead the charge to deal with public health crises, the rise of chronic disease, and then finally driving the future of medicine, innovation, reimagining medical education, and lifelong learning. So some of you know, the AMA got its start, in the 1840s, in an environment that's actually kind of similar to where we are today. One of the most important roles that the AMA had when it was founded was identifying and stamping out snake oil and quack remedies that endangered the health of the public and greatly undermined the institution of medicine, including trust in physicians. That's still one of the most important roles that we have today, as we've seen a surge in hostility directed at science and scientists since the early days of the pandemic. And the rhetoric, whether it is emanating from somebody in a position of power, has very serious consequences on patient health. And This was true throughout the pandemic, pushing back on outrageous claims around unproven treatments like ivermectin, trying to support vaccine efficacy, and we have to continue to do this work today. And unfortunately, this has just continued to erode public trust in the advice of experts, including doctors and scientists, to help us make sense of what's happening, to help us make the right informed decisions about our health. And it's our view, it's my view, that as physicians, as physician leaders, we have an obligation to push back on medical misinformation when we see it, always stand up for science, and call it out when it is coming from our colleagues. We have to hold our colleagues accountable when they deliberately spread falsehoods online, and the AMA has been working with state licensing boards on that effort. So there's a lot there, and of course, we have been trying to work with media companies, and we sat down with most of them, we sent them letters, and that was going pretty well until one of them was bought and sold and changed paradigms, but that's a story for a different day. All of our primary federal advocacy efforts has been bundled into what we call our recovery plan for America's physicians. We launched this in 2022, and it's pushing for reforms in 5 key areas. These will probably be very familiar to you. One is reforming a deeply flawed Medicare payment system that has not seen a real inflation update in 2 decades, requires burdensome reporting of meaningless, irrelevant measures that do not help me in my practice. Maybe they help you, I doubt it, and has yet to implement any of the dozens of innovative care models that physicians came up with, but CMS has sat on, things that we know would actually improve quality and reduce costs. We deserve a system with financial stability. That means automatic inflation-based annual updates that take into account the fact that we do have rising practice costs. The second item is supporting physician-led care teams and stopping the scope of practice creep. The third is fixing prior authorization to get rid of the overused, burdensome obstacles that get in the way of caring of our patients. The fourth is reducing physician burnout broadly. And the fifth is trying to make sure that we have the right digital health tools that are an asset, not a burden. Now, are reforms possible in the very challenging political space that we have to operate in Washington? We think so. We recently secured a huge win for physicians and for patients when CMS issued a final rule that has the force of law that will bring much needed reforms to prior auth in any program that is touched by the federal government. If it's sold on the exchange, it's covered by this. If it's Medicaid, if it's Medicare, it's covered by this. And the new rule will require all of these government regulated health plans to reduce timeframes for prior auth decisions, to publicly report program metrics for the first time. How long did they deny things? How often do they deny things? And this is going to improve transparency as patients are shopping for plans, and it will reduce care delays. It's going to require plans to have electronic integrated prior auth into our electronic health records. So getting rid of the faxes and the phone calls so the information can flow from system to system that will reduce all of those burdens on us. And HHS has estimated that they gave $15 billion in administrative costs to physicians and physician practices. These changes build on a variety of regulatory requirements that we are continuing to push for, and we are working on additional reforms that will require congressional action in the private plans that aren't regulated by CMS. Now, we know that there are a lot of issues that jeopardize patient care in different ways. And one issue that continues to be a huge focus of our advocacy is just the Medicare payment problem. And as you know on this chart that I'm sure you have seen, adjusted for inflation since my first year of medical school in 2001, Medicare reimbursement has dropped 30%. 30%. What industry could have a 30% drop in revenue and survive, right? Nobody. We all understand that this is not just about how we get paid, physician paid. It's about building a sustainable model that supports physicians, particularly colleagues, under tremendous, enormous financial pressure. So we continue to press Congress on this issue. Unfortunately, because of congressional inaction at the end of last year, we had another devastating round of payment cuts on January 1st, 3.37% reduction that went into effect. We were able to eventually get a little bit of that mitigated. So Congress opted to reverse 1.68% of the 3.37% payment reduction, it's still a cut. That is a mitigation to a really bad problem. But we have to do better. We have to urgently fix this system that's not sustainable, and that continues to be a big priority for us. So if you haven't contacted your elected representatives, the Fix Medicare Now website, the QR code, make it super easy to do so, and we'd encourage you to do that. Now, another piece of our federal advocacy plan is around burnout and alleviating burnout, holding on to our colleagues that are in practice today is such an important piece of a larger conversation about workforce shortages. And we have a multi-part strategy to attack the drivers of burnout at the root level. And it's getting rid of the things that just make it hard. And of course, that is something that we need to make sure we do while supporting the mental health needs of physicians. And unfortunately, there are too many colleagues who, when they know they need help, are afraid to get help. And the latest Medscape survey on this found that 2/3 of physicians who knew they needed professional help because they were in crisis, they were burnt out, they had a substance use disorder, they were afraid to get help because of stigma, because of concerns about their license, or they couldn't have access to the resource. So the AMA is doing a lot to elevate the mental health needs of physicians by trying to create tools and resources and support systems, doing our federal advocacy work. We've done a lot of work in partnership with the Dr. Lorna Breen Healthcare Heroes Foundation, including getting the bill passed in 2022, a bill that we strongly supported to get regulatory relief. We have gotten more than a dozen health systems to change their credentialing forms. How many of you, the last time you re-credentialed, had to answer a question that asked something like, have you ever received mental health, behavioral health, therapy, counseling at any point in your life? A lot of you have to answer that kind of a question. It's ridiculous. It is stigmatizing. It is not helpful. We should be asking questions about current impairment, not did I have a problem in high school that I saw a therapist for. In fact, a colleague of mine, we were residents at MGH, she went to Colorado to practice, and she applied for her Colorado license, and she had seen a therapist in high school, and she was a very high functioning adjusted person, and she checked the box, yes, I received therapy. And it took her 6 months additional time to get licensed because she answered that question. So we know what happens. People are afraid to get help because they know that they'll be asked those questions either at the state level with your license or at your practice level when you get credentialed at a facility. We're working system by system, state by state to get rid of those stigmatizing questions. We also have something that's been very popular, our AMA Joy in Medicine Recognition Program. This is a way for us to honor large health systems, hospitals, medical groups that demonstrate a commitment to preserving well-being, the well-being of our healthcare team members. And what it does is it basically provides a roadmap. How can you do this work at the system level? It doesn't need to be hard. It doesn't need to be reinvented. There is a playbook. If you follow the playbook, there's a way for recognition to be granted through that AMA Joy in Medicine Recognition Program. So there's a lot there. Now, while the recovery plan doesn't specifically talk about workforce shortages, we're trying to address it, and we're trying to get federal dollars to expand residency training programs. We're trying to get federal dollars to provide better student loan support, and we're trying to create smoother pathways for foreign trained physicians who already account for 1/4 of our physician workforce. So for example, the Conrad State 30 and the Physician Reauthorization Act bills would make necessary improvements to the J-1 visa waiver program to address shortages, especially in rural and underserved area. It is ridiculous that a physician who trains on a J-1 visa, who learns the American system, who understands how to deal with prior authorization, who has figured out Epic and Cerner, then has to leave for 2 years before they can practice in the US. It makes no sense. We're working on that. Of course, obviously, getting immigration reform through Congress is a bit of a challenge these days. So as we think about all of our work so that we can take better care of the nation, a big impact has been our change in strategy around health equity. And it's been long known that disparities among people of color, people from underrepresented groups are really directly linked to societal inequities determinants of health, education, socioeconomic status, mobility. And these and other factors are a big reason why historically marginalized groups suffer higher rates of chronic disease, heart disease, cancer, diabetes, chronic ailments. And these determinants, in many cases, have their roots in racist policies and practices. And the health gap amongst different races and communities is stark. Black and Latinx communities having disproportionately higher levels of chronic disease, especially heart disease. Cardiovascular disease kills nearly 50,000 Black women in excess of what we would expect annually. Black communities having disproportionately higher rates of cancer deaths, although white communities have higher rates of new cancers overall. These numbers underscore why so many need to continue to partner with us to work on it. Another troubling statistic around maternal mortality, and I won't dwell on this, but Black women 3 times more likely than white women to die from a pregnancy-related cause. This is an American tragedy that we have to consider as we do our work in health equity. So our AMA policy, which is voted on, debated, approved by the House of Medicine, the 190 states and specialty societies that come together, broadly defines health equity as optimal health for all, and it recognizes racism as a major public health threat and recognizes race as a social, not a biological construct. And we are trying to of ways. One of the most important things that we did was for health equity. We hired a transformational leader, Dr. Aletha Maybank. She was the deputy director of the New York City Department of Public Health. And the center is working to get rid of barriers that are keeping historically marginalized communities from accessing the care that they need. There's a lot of activity in the center. There's a very popular Prioritizing Equity webinar series that's available online. We have a medical justice and advocacy fellowship program in conjunction with Morehouse Medical School. We've worked with Essence to do our Release the Pressure national campaign to try to raise awareness of cardiovascular disease amongst Black women. And we've been a founding partner of the National Rise to Health Coalition, a collaboration of initiatives to advance racial justice across every aspect of healthcare. The AMA then released in 2021 a strategic plan around embedding racial justice and advanced health equity, an ambitious multi-year strategy to try to tackle this work. And there are 5 components. One is in everything we do as an association, embedding equity and racial justice. The second is building alliances with marginalized physicians and communities and other stakeholders to bring them to the table. The third is pushing upstream to get at those social determinants of health. The fourth is ensuring equitable structures and opportunities for innovation, which I'll touch on in a minute. And the final is fostering pathways for truth, healing, and reconciliation. And we now have a Truth, Reconciliation, Healing Task Force to explore the AMA's past and make recommendations about the future. Now, another, of course, important piece is making sure that we educate the workforce on these issues. And if you're interested in any of those resources, you can find everything from what we've put out through JAMA, the JAMA Network, our Journal of Ethics on the AMA Ed Hub, and it's all free content available for all of you. Our health equity strategy, of course, shapes all of our work at the state and national level as well, including all of our work around the Black maternal health crisis that I won't have time to go into today. Finally, I'm a data guy. Oguji knows this. And having the right data in the right place to drive decision-making, understand what's happening to our patients, and actually deliver better care is critical. And unfortunately, social determinants of health, whether a patient has stable housing or access to a refrigerator for their medicine or food insecurity, those elements are typically buried in notes, inaccessible as structured text if they are available at all. And so we have been partnering with something called the Gravity Project. We're a founding member, which is a national collaboration of public-private entities launched in 2019 with the goal of creating consensus-driven data standards to support the collection, use, and exchange of social determinants of health data. So they're doing some really great work to make sure that we have the standards to actually capture and collect that information. We're also working very hard on creative ways to increase physician diversity through scholarship assistance pathways, our work in the federal courts to protect immigrant physicians and medical students. And obviously, we were deeply disappointed by the U.S. Supreme Court decision that effectively ended affirmative action in the country this past year. So I want to take a little bit of a closer look in the last 10 minutes that I've got about how we're driving the future of medicine to improve the development, the design, and implementation of health technology. So any technology, whether it's an AI-enabled tool or a digital innovation, there are 4 drivers of physician adoption. And we see this over and over in all of our survey work that we do with physicians and members across the country. The first is understanding, does the thing work? And that foundational question should be straightforward, but it's not. It's not in digital health, because for a new biologic, a new drug, a new therapy, there's a package insert and there's a table 1 and you can see the study. For an app or an algorithm or an AI tool, the level of evidence that ought to be required before something's brought into the marketplace is uncertain. And the FDA has said that they do not have enough people, they will not have enough people ever to individually evaluate apps, AI algorithms, things that are embedded in systems. And so that means we will be stuck in many cases relying on post-market surveillance or other frameworks to understand, do these things actually work? But you all know what that means when you have a product that you're using with the patient. The second is payment. If I go through the acquisition costs of acquiring new technology, what's the pathway to payment? The third is liability. And I'll just mention some idiotic things that are happening in the space. So there's a federal proposal out right now out of HHS. It hasn't been finalized. It's been hanging out for 2 years. It basically says, if you as the clinician, the end user, rely on an algorithm to make a decision related to a patient and something goes wrong, you solely, the end user, are liable. Not the developer, not the implementer, not the manufacturer, even if they did something horribly wrong with the algorithm. That will kill the market for a lot of these innovative products that we know can help. And so we have pushed back very forcefully around that liability point because we have to get this right. And there's a little jump for joy from the sort of med tech industry when that rule was dropped. And then they realized, oh, actually, that will kill the market. And they did a 180. And it's actually kind of interesting. They follow their comments in the Federal Register. The final question is, does it work in my practice? And obviously, a lot of technologies that have been developed have not translated well. And I will admit it, I made this mistake. I once upon a time, because I do a lot of AI, CDS development, built some technology in our adult hospital, and it was wonderful, and we turned it on, and it was working. And then like an idiot, we just turned it on in our children's hospital. And for many of you, remember that children are not small adults. The workflows are different. Things are very different, and making sure that these tools actually translocate into the place that they're being used is such an important question. AHPBA does a lot to try to influence innovation. There's a lot of things that we do to try to guide it and inform it and fund it and validate it. And if you're interested in learning more, there's a lot of information on our website. We do have an innovation company in Silicon Valley. This is not a startup. It is a wholly owned subsidiary to birth startups, and they have launched about 12 companies. These are physician-led, physician-driven companies bringing things into the marketplace that hopefully will move the needle in areas around chronic disease, productivity, data liquidity. And I hope someday the AMA gets money back on the huge investment that we've made, about $50 million at this point. But if we never get a penny back, but some challenge that nobody else was dealing with in the marketplace gets fixed, it was worth every penny. It's a mission play. Now, as I think about, obviously, technology development and what's happening in our equity work, I want to just mention, what does it mean to design innovations, to design technology from an equity lens and why it matters? I'm sure many of you know the story and the attention that was brought to the problems with pulse ox during COVID. Well described by researchers at the University of Michigan that are off the shelf. The thing I used on Tuesday in my operating room, pulse oximeter, is miscalibrated, and it is still miscalibrated for patients with dark skin tones. It overestimates oxygen saturation. And during COVID, that was leading en masse to patients of color, not being triaged to higher levels of care, not getting supplemental oxygen, not going to the ICU, and caused harm. And the shocking thing about this is not the miscalibration. The shocking thing is we have known about this for 30 years. It's well described. It's in the literature. You can see it in comments to the FDA. There has never been an urgency to address this problem. And if we are not very intentional, very explicit in making sure that new innovations, new technology, new devices, new applications, new AI algorithms work for everybody, we will repeat the same mistake over and over and over. We need to do better, and that's why we created the Info Health Initiative with 14 other collaborators committed to amplifying those principles into the work that they're doing at the intersection of health and equity and innovation. And the whole idea is to invest in innovations from and for historically marginalized communities while trying to engage the industry to make sure that these things actually work. So not a day goes by, sometimes it feels like an hour, that I don't get asked about, what's happening in AI. You're an AI expert, you're always talking about AI. We do a lot of survey work, and in August of last year, we did a nationally representative sample about physician perspectives on AI. And if you are kind of interested, kind of excited, but also quietly terrified of AI, you're not alone. Because that is where 41% of physicians are today. They are equally excited as they are concerned about these technologies. What do they mean for the physician-patient relationship? What do they mean for our ability to practice medicine that actually makes bias less, not worse? How do we make sure that we deal with issues around cybersecurity and privacy? And what information do we need before we adopt a tool? So the AMA likes to use the term augmented intelligence when we talk about AI, not artificial, because the goal isn't to replace us. The goal is to boost our capabilities, make us more capable, make sure that we have some ability to not make omissions because of accident, mistake, or the fact that we're just exhausted. That being said, there is a lot of uncertainty about what the regulatory approach is going to be, and the FDA is trying to sort this out. We have a whole set of principles around what should development and deployment and use of these tools look like. If you're interested, you can find them out. These principles got a major refresh in the fall, but we've been working on them since 2018, so they're not totally new. And they basically say that above all else, health AI has to be developed and deployed and designed in a manner that is ethical, equitable, responsible, and transparent. And our principles really emphasize the human-centered healthcare nature of what we do. And we have to make sure that there is always a human in the loop who can intervene if there's a problem with an algorithm. And that comes back to this question about transparency. And I'll go deep on this for a sec. So there's a difference between explainability in an algorithm and transparency. Explainability means you know what it's doing, and that's hard. That's hard with deep learning and large language models. It's hard to know exactly why a result is being presented to you. But that's different than transparency. Transparency means that I know that my ventilator has an AI algorithm in it that's trying to optimize inflation pressures. And we should demand that in any setting in healthcare where there are algorithms using AI embedded, that there's transparency around the tool being a part of it. And this lesson is really easy to understand if you look at another industry that made that mistake, which is the airline industry. So who flew here on a 737 MAX? Yeah, so not the most recent 737 problem with the door thing, but the original tragedy that led to the loss of 2 aircraft, hundreds of people died, was because of an AI safety system. So for those of you who are, aeronautics geeks, the larger engines and the new position on the wings, you get more lift on the plane. That's fine. It causes the nose to go up during normal flight. And Boeing recognized this. It's an aerodynamic change. So they created an AI safety system. And what MCAS, Maneuvering Characteristics Augmentation System, does is when the plane's flying and its nose starts to go up, the sensor knows that, the AI safety system automatically pushes the nose down. The pilot doesn't do anything. problem happened when the sensors malfunctioned and the plane was flying normally, but the sensor thought the nose was up and it just pushed those two planes into the ground, tragically killing hundreds of people. Again, the mistake here was that the pilots had zero awareness of this new AI safety system. There was no training. It was not in the operations manual. We cannot ever allow that to happen in healthcare. We always have to know if there's an algorithm that it's there, even if I can't tell you exactly what it's doing, because that's the only way that you can hit the off button if there's a real problem. So the probably best, most articulate person in the space around this idea of the humanity of technology is a friend of mine, Abraham Verghese. He's at Stanford, and he's very well known for his book, Cutting for Stone, although he's written some other good books too. And he says that the way to think here is not technology versus the human, but to ask, how do they come together where the sum can be greater than the parts for an equitable, inclusive, human and humane practice of medicine. So it's so important that we earn and keep the trust of our patients. There's going to be a lot of actors externally, regulators that influence that. We need, of course, to keep our trust, the trust of physicians, as we think about what we need from lawmakers. And despite all of this, despite the uncertainties, what I will tell you is while there is so much riding on the shoulders of everybody in healthcare today, I am tremendously hopeful. And, in spite of all of the stuff that's going on, everybody shows up, we do the work, we're compassionate, we make a difference, and we can change lives. And we will only be successful in driving this forward if we come together. And obviously, I'm privileged to spend this year at the AMA doing our part. I will just, in conclusion, say that, there's such tremendous workforce pressure on all of us in all sectors, and it's a global phenomenon. It's not a US issue. We have to lean into technology to boost the capabilities of our care teams if we're going to solve this. We cannot open enough GME programs or medical schools fast enough. It's about using technology and doing system redesign. There's tremendous potential to use AI to scale the capacity of our teams. But AI will never replace physicians, but physicians someday who use AI will replace those who don't. So I'll end with the last 30 seconds with an adorable picture of my children, Ethan and Asher. And if there is time, I'm happy to answer questions. Otherwise, I'll just hang out outside after the talk. Thank you. Yeah, okay. We're at time.
All right. Thank you. Thank you so much. Thank you, Dr. Ehrenfeld. And we have an afternoon break. I know Dr. Ehrenfeld's offered to be available outside the room for more direct questions. And we'll go for a break now and continue on with the rest of the program. Thank you again.